Next. Excellent. So I'd like to acknowledge on this day in Indigenous Peoples Month that we're on the land hosting this session on the unceded ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, as well as the Métis Charter Community of the Lower Mainland region. And as always, we ask us to reflect on the teachings of Indigenous people, our perhaps less attentiveness to what they have to teach us, especially when it comes to the earth and the land and perhaps even food, as we're about to hear shortly. And wherever you are in this province or country, reflect on ways that you can learn more, do more, and be more attentive to the tenets of truth and reconciliation. Next slide. So Province-Wide Rounds is a collaboration between the UBC Division of Nephrology and BC Renal. We depend on all of you in the Health Authority as well as our industry partners to facilitate and ensure that we have ongoing participation in this and education for all to improve outcomes for patients. Next slide. So it's really a great pleasure to be able to introduce the following three speakers. So Dani Renouf is the Renal Resource Dietitian for Providence Healthcare and the Chair for the Dietitians Committee for BC Renal. She's been in practice for over 20 years and has worked in a variety of different clinical practice areas and divides her time at the moment doing patient care through the KCC at St. Paul's, administrative and leadership duties, staff and patient education, as well as some exciting research projects. She's been publishing lately on planetary health and fad diets and enrolling patients for a Kidney Foundation of Canada study on nutrition and microbiota being conducted in the Lower Mainland. Anja Webster has been a clinical dietitian for over a decade and currently works at the post-kidney transplant clinic at St. Paul's and has also been involved in a number of research studies, including looking at vitamin D status of kidney transplant patients, as well as the prevalence of dyslipidemia after kidney transplant, and is involved in a number of research challenges looking into the use of natural health products and medicines by kidney transplant patients. And last but not least is Kelly Picard. She's worked as a clinical dietitian since 2008, and the majority of her practice is spent in chronic disease management. She works for Island Health and the Nanaimo Kidney Care and Transplant Clinic. In addition to her clinical work, she received her PhD in human nutrition from U of A in 2023, and her research focuses on how food processing is impacting medical nutrition therapy for people living with kidney disease, with a special interest in hyperkalemia management. So with that very educated and thoughtful group, I'm going to turn it over to the three of you to tell us the 4 Ps of kidney nutrition. So over to you, and thank you very much for the time that you take with all of our patients, but also to educate us. Looking forward to this.
Thank you so much. Good morning, everyone. Thank you for being here with us. It's a really exciting time in nutrition and kidney disease, as you can see by our wonderful array of panelists and their talents and skills. So without further ado, I'll jump into what we call the 4 Ps of nutrition. Very exciting that we have the new KDIGO Guidelines that came out in 2024. I'll be discussing those, and then I'll hand over to Anja to discuss protein management in our population. And finally, Kelly will enlighten us with some exciting cutting edge and novel findings in the world of potassium and phosphorus. Thank you. So the objectives today are to review the KDIGO 2024 nutrition guidelines with a focus on protein, phosphate, and potassium, to review protein recommendations and how to interpret clinical findings to implement them into nutrition practice and make them patient-centered and accessible. Finally, we will wrap up with phosphate and potassium to review both in terms of food additives. That's really what we'll focus on today. Thank you. Next slide. So the practice points that I'd like to focus on from the KDIGO 2024 guidelines are the practice point around the philosophy of healthy and diverse diets that really focus on a higher consumption of plant-based foods as compared to animal-based foods. There are a myriad of reasons why this recommendation has been established, and I'll go through some of the reasons why in terms of the literature. and then looking really at lowering consumption of ultra-processed foods. The other practice point that's very, very important and probably very unique as compared to other guidelines is the actual call out to renal dietitians as accredited nutrition providers to provide education to people with CKD about dietary adaptations. It's really not just about, you know, an AI generated meal plan. It's really about how to bring that to life for patients with the social determinants of health and with food access and planetary health considerations in mind, and really to tailor to individual needs as well as comorbid conditions. So that's really what we do. And so that's a very important practice point for us. So this schematic is really highlighting exactly what I just pointed out. And what I love here again is that the lifestyle piece is front and center, and it includes a healthy diet, physical activity, smoking cessation, and weight management. These are all very, very important considerations in view of the obesity pandemic. And so early intervention for folks with CKD is very, very important to help prevent the complications and to delay progression to end stage. And we know that nutrition is pivotal in preventing and managing conditions like metabolic acidosis, chronic hyperkalemia, hyperphosphatemia, and really to prevent protein energy wasting. And we will talk quite a bit about that. Next slide. So first, I'll go into the concept of plant-based diets. What does that actually mean? It's very difficult to really define what a plant-based diet is. It's a pretty nebulous and broad term, but really, if you are consuming more than 50% plants in your diet in a day or over a given time period, you are, you know, plant-based. Within that spectrum of plant-based eating, there are different types of diets. So we have on the far left, the strict vegetarian or vegan diet. This diet excludes all animal products. It's not a diet that we promote for our patients. It's a diet that's out there, and some people, you know, wish to follow it for various reasons, but it's not mandatory that our patients be on a vegan diet to eat plant-based, if that makes sense. On the other end of the spectrum is the flexitarian diet. That's a diet where we basically are omnivores. We eat everything, but we have a concept of proportions, amounts, and we still are heavily focused on plant-based foods, you know, providing most of what we eat. So this is the type of diet that we provide as guidance to our patients, and it includes a variety of dietary patterns that I'll go through. In the middle of the spectrum are your, you know, ovo-vegetarian, lacto-vegetarian, pesco, lacto-ovo-vegetarian diets, and then the vegetarian diet. So I just wanted to show you this because a lot of our patients ask us, you know, what I read about the plant-based diet, what does that actually mean? So this is kind of how we lay it out. Next slide. What I really, really like about the word plant-based eating, or this dietary pattern as set out by KDIGO, is that it really enables different traditional diets to become front and center. Historically, what our teaching tools have done is provided a very Western or you know, one-size-fits-all dietary approach, which we now appreciate is inappropriate and not patient-centered at all. So what we're shifting our practice toward is really what are traditional foodways for people, what are foods that make people feel well, that allow them to connect with their culture and sense of well-being. And those are the foods that we tap into when we talk about a plant-based diet. So here we have a Mexican plate, and it includes a variety of plant-based foods. It includes a lot of whole foods, and it's still in line with the staples that are reflective of a Mexican diet. And we see more and more folks from Central American countries coming to Canada. So it's really important for us to be familiar with this way of eating and to help promote traditional foodways as much as possible. In the next slide, you'll also see the Indigenous food plate. Now, Adira alluded to the importance of getting familiar with Indigenous cultures, the diversity within these cultures, and the foods that they honor and value. And not only for individual well-being, but also for planetary health. There's a lot of knowledge, ancient knowledge within the Indigenous foodways. And so I took this from the First Nations Health Authority, and this plate is very, very balanced, but is in line with what communities may have in terms of access to food, or if they are doing their own fishing, growing some food. We really want to promote this type of balance. Next slide. Another cultural group that we serve within the urban KCC here at St. Paul's is the Chinese culture, and also very important to honor the ways of cooking that are in line with the plant-based eating. And so you see here some poaching of fish, the wild rice or the red rice, and then the Asian vegetables that are favored are also shown here. Why I say this is because a lot of patients come and say, could you please give me instructions on what to eat? I don't think eating my way is right. I think that's why I got sick. So it's a lot of reassuring people that actually eating in line with their traditional food ways is very important and healing. Thank you. Next slide. So why on a clinical level does plant-based eating matter? Plant-based eating is very important in the prevention of stones. It actually prevents the formation of citrate stones in particular. And so it's very, very important in terms of creating that inorganic base environment to prevent stone formation from occurring. The other component that is important is acidosis prevention. Plant-based foods tend to favor an alkaline environment, and again, that helps prevent acidosis. It helps raise bicarbonate levels, which is very important. And on a gut microbiota level, the fiber content of plant-based foods not only helps with digestive health, but also, in fact, helps to shift the gut microbiota to favor saccharolytic bacteria, which then in turn protect us against inflammation and pathogenic concerns and illness. There is a gut-kidney axis, and so there's a lot of what we call kind of interplay between the organs as well, and food can shift that conversation through the production of short-chain fatty acids, in particular butyrate and acetate. And that feeds back to really reducing the burden on the system in terms of acidosis, which preserves EGFR, decreases bone resorption, and improves insulin sensitivity, and it also protects muscle mass. This is all because these plant-based diets are in essence reducing inflammation. So it's very important that people stay the course and that this becomes a lifestyle for people. Next slide. In these longitudinal cohort studies, and I appreciate nutrition is an observational science at the best of times, and therefore we rely on large studies with big sample sizes over time to make our recommendations in the absence of randomized controlled trials. So in these very key studies, including Crick and Haynes, CardioPrep, we see that the DASH and the Mediterranean or plant-based diets, so diets that had the highest plant ratio, tend to favor CKD protection, so prevention of progression, reduced mortality, and also help with other parameters such as blood pressure, dyslipidemia, and insulin sensitivity. So these types of diets are metabolically protective, and they help protect the kidneys long term. And so we really believe that as a result of these studies and as per KDIGO guidelines, these plant-based dietary patterns are sort of our focus right now and quite important. Next slide. In this particular slide, you'll see that when we focus on the source of protein, because you may ask yourself with the plant-based diet, how about protein? When you look at substituting plant for animal-based protein, the results are mixed, with some showing benefit of plant over animal-based diets and others showing no significant difference. When it comes to protein, it appears that when you're trying to protect muscle mass, the adequacy is what's key rather than the type of protein. And we note that some plant-based proteins need to be present in order to reduce the acid load. That's why the flexitarian dietary approach appears to be, at this time best in terms of trying to control that interglomerular pressure that, is otherwise present when we overload the kidneys with too much protein. The really key priority, I think, is muscle mass metabolism. And as you will hear Anja speak about this further, we have more and more folks presenting with sarcopenia. And so it's very important that we really look at total amount of protein when we're providing care to patients. These are very, very promising findings. And so we have actually put in place some online nutrition classes to educate patients early on, as the KDIGO guidelines indicate, as upstream as possible to try to start to implement some of these plant-based approaches. Next slide. All right, exercise. I call this everyone's responsibility. Next slide. So the recommendation is that we, and that's everybody on this call, recommend that people with CKD be advised to undertake a moderate intensity physical activity for a cumulative duration of at least 150 minutes per week. So this is the ideal. I think at this point, all of us have an opportunity to speak to our patients about what type of exercise or movement they enjoy doing. That could be housework, gardening, could be anything that involves movement, and to really validate that and encourage that. People are often at high risk for falls. They're embarrassed to share, so asking about that is very, very important so that we can either direct them to a physiotherapy program or a professional who can provide them with modifications to exercise. And physicians should consider advising, encouraging people with obesity and CKD to lose weight. Now, as dietitians, we may have some wording suggestions for that, because people hear all the time that they need to lose weight, and they will take dramatic measures to do so. But I would argue, and I think my colleagues would agree, that in fact, promoting ways of eating, promoting ways of movement that create motivation is a much, much better tool for changing metabolic health. And that's really ultimately what we want. And even a small percent weight loss, 5 to 10% body weight for folks in the obese category can be extremely helpful. And they may not feel as patients that that's valuable. So it's very important for us to have knowledge on what losing weight actually means and what that looks like for people, and to really put in place a sustainable interdisciplinary program that allows people to feel good about the weight loss and keep it off. The next slide is a pooled meta-analysis of exercise studies that look at strength-based or resistance exercise. Now, the studies are far and few. Look at the very, very small numbers. There aren't many studies that have looked at resistance exercise in kidney disease. But according to these studies, folks who started dialysis are already at a 30%, 30% of them are already muscle atrophied. They're already sarcopenic. So we know this because 40% of our patients on dialysis are on nutrition supplements at any given time across the province. We have a huge population of sarcopenic patients. And so there is a huge correlation, a significant correlation between the reduction of lean mass and the severity of kidney disease and physical function. Therefore, promoting resistance exercise, by increasing the 6-minute walk test, as you can see, by improving grip strength, and by improving the hemoglobin A1C, you can see that this resistance exercise in folks who are at end-stage kidney disease or on dialysis can actually help restore some of those atrophied muscles. And so programs across the province can really tap into this opportunity. Next slide. So the benefits of exercise cannot be underscored, and they're all listed here, and you're probably familiar with all of them. Yet we don't speak enough to our patients about exercise. I don't know where we fall short of doing this. It is a prescription that we can provide. I think we can talk to every single patient about this, irrespective of ability, and you know, we can certainly promote them doing whatever is feasible for them that makes them feel good. So you can see how dialysis patients who have exercised have just much better overall outcomes as compared to those who didn't exercise. And interdialytic biking is a really good example of that. Next slide. I also wanted to mention about exercise that the cognitive status of patients has been shown to improve with exercise, even 3 to 5 times a week in a home-based environment. So this is another big piece. People are always asking me, how do I improve my cognition? Should I be taking creatine? You know, and movement can really help restore that naturally without having to take any supplements that might put additional burden on the kidney. So implementations to practice about exercise, I think really honing in on the dialysis centers, helping support programming as we do here at St. Paul's. We're really fortunate. And then also for folks who want to do home-based exercise, the Staying Active tab on the Kidney Wellness Hub has amazing videos. I really encourage all of my patients to go. We have cards that the Kidney Foundation has provided us that we give out so they can quickly access the videos from the comfort of their own home. And I recently learned about PARX, PAR-RX, so you can actually prescribe nature to your patients, and you can register to be a prescriber, and then your patients will have access to national parks across Canada for free. So I will, with that happy note, pass over to Anja, because we are short on time, and I will let her about protein management. Thank you.
Hello, thanks, Dani. Okay, so we're going to shift gears a little bit, but still focusing on the planetary eating, and we're going to chat about protein. Next slide, please. The practice standards we're going to review today are the protein recommendations for CKD. We won't go into the very low protein diets, supplementing with essential amino acids or keto acid analogs, because it's not a practice we do here at St. Paul's Hospital. But we will touch on the importance of not prescribing low or very low protein diets in metabolically unstable people with CKD, and then also really focusing on protein recommendations for our older population, especially those with underlying conditions such as frailty and sarcopenia. Next slide. Before we get into our current recommendations, these are pictures I snipped from some of our old handouts. And if you can get past the Comic Sans font, you can really see that these were white. We had a lot of words on there, not a lot of pictures, really focused on animal proteins. If you see, there's even asterisks next to the peanut butter and the cheese, and no beans or lentils really listed on these handouts. And that was because for a very long time, we focused on what we call high biological value protein and really pushed meat proteins, partly because of the fear of not getting enough protein for patients who needed more, but also because there was a lot of focus on avoiding high phosphorus or high potassium foods, and beans and lentils and nuts and seeds were really part of that high phosphorus, high potassium group, which Kelly will get into more detail later. If we look into what our current recommendations are, and I'll show you some handouts later, but at St. Paul's Hospital for stages CKD 3 to 5, our recommendations are similar to the general population, 0.8 with up to and no more than 1.3 grams per kilograms. We increase when you get to dialysis between 1 and 1.3 grams, depending on the form of dialysis. And then for our post-kidney transplant patients in the early period, we recommend 1.2 to 1.5 grams per kilogram. And that these higher protein needs for the early post-transplant period are to help with healing after surgery, to also outbalance the effects of corticosteroid use in the early post-transplant period. And also there's some evidence to suggest that higher protein in the early period can help prevent infections in the early post-transplant period. After the first 4 to 6-ish weeks, when patients are more healed, we'll switch to a lower or more maintenance protein for our post-transplant patients, which is 0.8 to 1, and they'll stay on this for life, or unless their allograft fails, in which case we'll lower protein recommendations. Next slide, please. So as Dani has really already primed us on, there's a lot of focus now comparing animal and plant-based proteins, or really having this plant-forward dietary pattern and dietary eating. And why that focus is coming more about now is, as you can see, when plant-based proteins were replaced for animal protein, there was positive effects on gut microbiota, lower cardiovascular risk, lower inflammation, lower CKD progression, and lower metabolic acidosis, which are all positive effects when it comes to CKD progression and chronic disease management. Next slide, please. So what we're going to focus on today is really what does that mean when we are recommending protein, when we really want to focus on preventing sarcopenia and protein energy wasting. And we know the importance of making a recommendation for the amount of protein a patient needs and the type of proteins patients need. We know our CKD population is at higher risk for sarcopenia, especially as the CKD progresses and we get closer to dialysis and we have our older patients. Aging affects it, malnutrition, as patients have been focused, or especially for some of our long-term CKD patients who have heard that they had to only eat white foods or have been really restrictive on their diets. Low BMI from weight loss, physical inactivity, especially for our dialysis patients who are sitting at a dialysis machine for 4 hours, 3 days a week. So why does protein matter when we talk about sarcopenia or protein energy wasting? And why did we really focus on animal-based proteins before we had more of this knowledge about this chronic disease management and plants? The reason is because protein is the building block of muscle repair and growth, and animal proteins contain all the essential amino acids, and they're more easily digestible, whereas plants are lower levels of some of the essential amino acids, and because plants contain anti-nutrients or things like fiber that prevent us absorbing all of the essential amino acids. That being said, there's more and more of a push now to include plants because, as Dani has already really showed us, people don't eat one type of food. Nobody goes home and eats steak for breakfast, lunch, and dinner and only steak. Nobody goes and eats just beans for breakfast, lunch, and dinner. Everybody eats in a different food way. And because of this, we know because all the plants have the essential amino acids, but in different amounts, when we combine them, then we can get all the essential amino acids. And because of the anti-inflammatory effects of having a plant-based diet, that's actually beneficial when it comes to muscle building and muscle growth. So what dietitians really focus on is recommending a plant-forward or more plant-based eating, and even just getting some form of plants within the diet, whether it's adding some beans into a stew or lentils into a pasta and bolognese sauce, just so that you still get some of those benefits from the plants. Next slide, please. This is just a summary of a systematic review. It did look more into healthy, as Dani said, there's not a lot of research in the CKD population. Look at healthy patients and particularly older patients, and looked at resistance exercise training. And what really was, when they replaced animal protein with plant protein, the type of protein didn't matter when it came to muscle wasting. What really matters is the amount of protein and the amount of calories eaten. So when we are making our recommendations, we really need to look at how much protein and how much patients are eating. And when patients are struggling with eating, that's when it really comes when it really becomes important to make specific recommendations without just saying you need to follow a vegan diet or you need to follow one sort of way of eating. Next slide, please. So how do dietitians do this? How do we assess and how do we make our recommendations? Every time a patient comes into the clinic, especially for their first assessments or into our outpatient clinics, we do a nutrition assessment, which involves a subjective global assessment or SGA, where we look at the nutrient intake. So are they eating enough? How much are they eating? We look at their usual weight compared to their current weight. So has there been a significant weight loss within the last 3 to 6 months? We're no longer really focusing on BMI. We're looking at everything that could be impacting the patient's health status. We look at symptoms of, excuse me, I'm recovering from a cold here. So we look at symptoms that could be impacting their intake. Are they having difficulty chewing or swallowing? Are they having any excess losses through diarrhea, vomiting? Are they having feeling too full quickly? Any other symptoms or that could be onset within the last few weeks. And then in addition, we look at their functional capacity. So we know that inactivity can really lead to muscle loss. So has anything changed in the last few weeks or few months that's affected their ADLs? Next slide, please. Along with that, we will do a hand grip strength. So this measure can help us to, sorry, I apologize for my cough. This measure can help us to assess where a patient stands in their nutritional status, and but it only takes a few seconds, and patients really like this because it gives them a number and a goal. Before we do our recommendation, we will ask them to sit down and measure their hand grip strength. If their numbers are less than 18 to 20, we'll give them specific recommendations and potentially some even resistance exercises that they can do at home. And then retest them again in their next clinic visits in 3 or 6 months. And patients can really like that because they can see changes rather than just subjective changes. Next slide, please. Okay, so what have our handouts, how have they changed in the past few years? As you can see, a lot more color, a lot more food pictures, and you can really see there is these plant-based proteins on there. We've got tofu, we've got cooked beans, nuts, seeds, nut butters, and also these are available on the BC Renal website. And also because we know it's not just a westernized diet and we need to make recommendations that are for more cultural diversity, we do have these handouts offered in Chinese with particular Chinese food ways on our website. Next slide. These other ways that dietitians are supporting patients in incorporating more plants, as Dani's already mentioned, the Kidney Wellness Hub and the Kidney Community Kitchen not only have activity and ways to increase exercise on there, but we've got on-demand classes on there. We've got blog posts and recipe links for easy ways, because most of our patients, when we say they should eat more plants, or when I recommend tofu, the first thing is, I don't like tofu, I've never eaten tofu. But if you can show that there are easy ways to incorporate these beans or tofu or plants in small amounts and the benefits that they can have, these are really positive for patients. Finally, if we assess when we've looked at all the different ways that patients are eating, we've looked at their hand grip strength, and we're really finding that patients are not meeting their protein or their energy requirements, the BC Renal has an oral nutrition supplement program. And these ones listed here are just a few of our renal specific ones that dietitians can recommend and in order for our patients to help them meet their needs and prevent extra muscle loss. And the Beneprotein is our protein supplement for those who only need extra protein. Again, we reassess this every few months before we order more supplements and really focus on if anything's changed and how we can keep recommending food ways to help our patients. And with that, I'm going to pass it on to Kelly, who's going to chat about potassium and phosphorus.
Thanks, Anja. Yeah, so as Adira mentioned, potassium is my favorite mineral. I suppose if you've ever heard me talk, then maybe you've heard this story, but if you haven't, then I'll just share briefly why I find potassium so interesting. I was teaching a patient who was just starting peritoneal dialysis about ways of eating many years ago. And at the end of the teaching session, she said to me, okay, so I can eat Fruit Loops, but I can't eat bananas. And I just thought, as a dietitian, that she wasn't wrong. Bananas were on the no handout, and refined grains and processed cereals were on the okay part of our handout. And I just thought there's something has to change because clearly we aren't sending the right message when somebody thinks that a sugary breakfast cereal is more appropriate to eat than a banana. And so that really sort of started for me, my research and my interest in potassium. And as sort of Anja and Dani have both sort of been talking about, in terms of nutrition, we've seen this incredible evolution in what's been recommended for protein, for what foods, but also for potassium. And so you can see that back in 2004, by the KDIGO Guidelines, we just said everybody across the board needs to restrict their potassium. There's nothing in here about what's happening with the levels of potassium in the blood. It was just sort of an on or off depending on your CKD stage. By 2005, though, the CARI group, which is the Caring for Australians with Renal Impairment, they actually started to attach a target in terms of we're only going to start restricting if there's an issue. But they were also providing us with a total milligrams of potassium per day. And again, in 2010, that actually restriction became even more strict, and that was from the Americans with the Academy of Nutrition and Dietetics. The Canadians came out in 2015 and decided to be even more strict, saying 2 grams. So the Canadians are PEN, that's a practice-based evidence in nutrition. But within 5 years, KDIGO came out and started to say that there seems to be a lack of evidence that's been supporting this practice of a strict potassium restriction when somebody has high potassium levels in the blood. And the full KDIGO report said that it may not be necessary, and in fact, it may be harmful. And I think part of why that could be harmful is because patients were inadvertently walking away with the idea that bananas were bad, but Fruit Loops were good when we were restricting many of our traditionally high potassium foods. KDIGO was still sort of saying we think we probably need to adjust intake to try to maintain serum levels in 2020. But we can see that there really is a sort of this questioning of how are we doing it. And the Canadians updated in 2025, focusing on maybe we need to be careful about what types of potassium we are recommending restriction for, factoring in things like bioavailability. And so again, sort of similar to that old versus new that we've been talking about, one of the things that I find so fascinating about nutrition guidelines and nutrition practice in general is what you may have noticed on those guidelines is every single one on that last slide was talking about restricting potassium, but my patients don't actually eat potassium. My patients eat food. And so if I was to tell probably even myself in this room to only eat, for example, 2,000 milligrams of potassium per day, I wouldn't really know how to do that. What I would need to actually convert that to is to food. And so in nutrition research, there's always this fascinating translation where dietitians read something in a guideline, for example, to alter potassium intake, but then they actually have to turn that recommendation into food that patients actually eat. And so back in 2020, when we did this research, what we were looking at is across Canada, what was that translation of we need you to restrict potassium, but what foods were patients being told that they needed to limit? And really, what they were being told to limit, you can see in the graph here, is mostly fruits and vegetables. By far and away, there were over 200, almost 200 fruits and vegetables that patients were being told to limit or restrict. And if we look at sort of the types of fruits and vegetables, most of those fruits and vegetables were minimally processed fruits and vegetables. So the focus wasn't on potato chips or orange juice, which could potentially be a fruit and vegetable product, but really it was about restricting the whole banana, the oranges, the potatoes, the tomatoes, and sort of that list that comes maybe to the top of most of our heads when we think about high potassium foods. But one of the problems was, especially this is happening in Canada, this is happening across the Western world, is that Canadians and Westerners are really eating less and less of this minimally processed food. So this was actually data that we collected from people living with kidney disease in Alberta. And when we looked at the types of foods that they were eating based on the level of processing, what you can see is that the most of the energy intake for people living with kidney disease in Alberta actually came from ultra processed and processed food, and minimally processed food was actually the smaller portion of the diet. But if you compare the low potassium diet, we were saying that you really needed to restrict 71% of this minimally processed food, and only potassium was being found in the 30% section of where they were actually consuming most of their calories from. And so then the next question is that actually true? Is it true that processed food doesn't contain potassium? And so even though it's the majority of the diet, we should focus on the minimally processed chunk. But evidence actually really doesn't support that. And so this is a really interesting study. This is actually a feeding study, which is such an important nutrition research tool, because we actually know exactly what people are eating, and we have them in very tight conditions. And so we can really understand how different ways of eating are having an impact. I will tell you, this wasn't in kidney patients, so this is just in the general population. But when we fed people a diet that was matched for potassium, or pardon me, there was differences in potassium, but different levels of processing. So when we had a higher processed diet where we're using more juices, more sort of ready to go food versus foods that are going with whole grains, whole fruits and vegetables, what you can see here is that the potassium bioavailability was lower. And so the authors of this study actually concluded that the whole fruit and vegetable bioavailability was likely lower at 50 to 60%, even though I know you're not seeing that because, of course, people eat combinations of diet. We're not just able to isolate single foods in bioavailability studies, but the evidence suggested that a minimally processed whole fruit and vegetable had much lower bioavailability than a processed one, and that was sort of across the board in terms of processed food. And so there really is now a new approach to dietary potassium management. And the key thing is that we really want to focus restriction less on these healthy foods. In part, again, as Dani and Anja have talked about, the benefit of the fruits and vegetables, the benefit of these plant-based proteins like nuts and seeds, while they are high in potassium, sort of by true milligrams, they're not high because they have lower bioavailability. Patients actually aren't eating enough of these in general. And when we actually focus on the processed food, we are focusing on foods that are less nutritious in general and actually have better or higher bioavailability of potassium, and so therefore more likely to have an increase. And I think we can all in the room agree that, all things being equal, if I want my patients to walk away at the end of the session thinking about foods that are high in potassium, I want them to be focusing on potato chips, French fries, and chocolate bars. And I want them to continue to eat the fruits and vegetables that they might enjoy or are part of their diets. In terms of what I like to think about, and so this is a sort of pilot that we got started in Nanaimo, looking at patients living with kidney disease and with hemodialysis. We collected grocery store receipts to try to figure out where are there potassium additives in the processed potassium foods coming from. What you can see is that potassium was coming from their beverages. So things like soda pops, a lot of pop like colas actually have potassium in them. So we want them to be working on that. Things like hot chocolate powder, iced tea powder, sauces and salad dressings were big sources of potassium in ready-to-eat foods. So frozen pizza, frozen meals, and snacks. And again, I think if we think about foods that we think might be more nutritionally expendable for our patients, I think we can all agree that if our patients drank water and less Coke, they probably are better off. And in fact, they're helping to reduce their total potassium intake. So I'm going to switch briefly to phosphorus, although you probably won't be surprised to hear that there's been a similar evolution. And again, if we go back into the early 2000s in the KDIGO Guidelines, there was a restriction across the board for 800 to 1,000 milligrams of phosphorus. And as Anja sort of alluded to and talked about, that really did overlap with the protein. And so it's hard to tease out these two. So because of the connection of where phosphorus is naturally found in food, where it tends to be found with the protein. When we were modifying the protein by default, we were also trying to modify the phosphorus. But over the last 22 years, give or take, what you can see is that there has been now a recommendation that we need to consider source because we're starting to understand a lot more about bioavailability. And there is a lot more emphasis on individualization. And also, what I will say in the KDIGO Bone Mineral Density 2025 conclusion statements that just came out a couple months ago is there is sort of, I guess, more question about how does direct phosphorus intake relate to outcomes. And those of us are likely familiar with the ongoing phosphate trial, which is starting to try to study and understand a little bit more about how our targets for phosphorus and the sub-study phosphate diet in terms of how people are eating is actually going to be impacting important outcomes like cardiovascular and mortality risk for our patients. But again, if we sort of think about high versus low, so this is a similar thing where we looked at handouts across Canada. And what you can see sort of over the years in terms of that translation from a mineral, so restrict phosphorus to food, is that most of this burden falls on minimally processed dairy. So don't drink milk or cheese. Anja showed you that in that other handout for protein. We wanted you to avoid plant proteins. 100% of the handouts in 2021 recommended restricting plant proteins like nuts and seeds. And so this is where kind of that burden is. But interestingly, things like refined grains. So when my patient was saying, okay, I'm good to eat Fruit Loops, she wasn't wrong because this is really what our handouts were saying in terms of these foods seem to be at low risk of being high in phosphorus. And again, when we think about sort of minimally processed food versus processed food, I do think in general, phosphorus has done a better job of kind of balancing out or trying to match a little bit better. Are we only restricting minimally processed food or are we restricting processed food as well? You can see that there's a better balance here across the board over time, in part because phosphorus additives have been on our radar for a little bit longer. But just like potassium, it is important for us to consider that not all food sources have the same phosphorus bioavailability. And so this is a really cool summary that was put by David St. Jules. Sorry, the reference there got moved, so it's been cut off. But basically what they were looking at is they were looking at how diets that are made up predominantly of different sources could be impacting the bioavailability. And so what you can see here is that whole grains had lower bioavailability at only 41% compared to things like meat and cheese, or pardon me, meat and additives, where that bioavailability is over 50%, and dairy products is lower at 38%. So, we've traditionally restricted these foods thinking that we're doing this to help reduce the phosphorus exposure. But if the bioavailability of phosphorus from these foods, if we're not absorbing very much phosphorus from this food, then the utility of this intervention is much lower. And not only do we need to worry about the phosphorus additives, so that's things that they're adding to food, but whenever we process food, we also change the bioavailability. So this is a really cool study where they were looking at whole grains. You can see kind of the unchanged whole grains. There was processing, which ended up removing things like the tannins and the phytates. And then when they did an in vitro or test tube digestion model, what they found is that there was increases in the bioavailability of minerals. And I know this is in their graphic abstract, so they weren't focusing on phosphorus because this is a little bit of a interest mostly for us in kidney, but phosphorus bioavailability increased. So when our patients are consuming whole bran bran or oatmeal or a minimally processed grain versus a flaked breakfast cereal, the phosphorus in that food is actually much more bioavailable, in part because of the reduction of anti-nutrients like the phytates, the tannins, and the fiber. And what's really important to know is that phosphorus is common in processed food. So this was a study published again just a couple of months ago in March, where they looked at using basically food sales data. So this represented over 120 billion of consumer products in the US, and they found that 56%, so almost 1 in 2 foods contain phosphorus. So I just sort of, if we were to think about this little schematic, if our patients are walking down the grocery store in that middle aisle, really they should be avoiding, if they need to control their phosphorus, every second product they pick up likely contains a phosphorus additive that they need to be careful of. And in terms of where are those phosphorus additives found, and so I've just kind of added the red line into their graph. So carbonates, I did actually reach out to the author to clarify, because this isn't a term we use in Canada, but this was an American, and this researcher is actually Australian. So this is carbonated beverages. So where's the phosphorus coming from? It's coming from carbonated beverages. It's coming from confectionery, so things like chocolate bars, potato chips. It's coming from processed dairy products, things like plant-based milks and yogurts, ready meals and savory snacks, pretzels, cheesies, these sorts of things. And again, I think if around the room we can collectively agree that it's probably not a big stretch that things like pop or cheesies are likely less nutritious for our patients than nuts and seeds. And again, in terms of what we were finding when we looked into NIMO and used our grocery store receipts, where are our patients getting exposure to additives? So this is really nice to see a bit of a match with this much larger American study. But basically, it was the snack foods is where these are coming in, ready to eat foods, and bakery items. So processed or refined grains, things like commercially prepared bread, muffins, baked goods, cake, all of these foods tend to contain phosphorus additives. And again, these are foods that I would describe as less nutritionally important for my patient. I am just mindful of time, and I do want to open it. So I'm going to skip that section. And if you have questions about the accuracy of labels, then I'm happy to go back. But basically, so just to sort of conclude our key takeaways. So in an era of precision medicine, really, just like we're trying to get the right drug, the right treatment for the right patient, we are also trying to get the right eating plan and the right nutrition advice. We really want to encourage minimally processed plant-based foods. Not only is it better for their overall nutrition and health, we believe it to be better for their potassium, for their phosphorus, and for their protein. Protein recommendations are based on a holistic approach where really we are focusing on adequacy, the concept of sarcopenia, sarcopenic obesity, which is why the utility of the body mass index is increasingly being called into question, really means that we need to be thinking about our patients and making the right recommendation for them. And again, that traditional recommendation for potassium and phosphorus have shifted away from routine restriction. So we no longer restrict across the board. We are waiting for the right signal, and we are really going to try to focus on individualization and focus more on processed foods or less nutritious foods if we can, before we focus on restriction of the less processed food. So with that, I want to leave a few minutes at least for questions. So I will stop sharing. And I know there's a bunch I can see in the Q&A, so.
Yeah, no, thank you for the three of you for really an outstanding and very comprehensive thing. I will tell you, at the height, you had 118 people on the Zoom, and that's including people from all over the province. So great, and congratulations on, and also thank you for all the work that you do. And also, like everything else in medicine, things are changing, and we can't, what we thought we knew, we don't know, and now we have to change, and I think change is difficult. So this has been really, really helpful. I'm going to try and bunch some of the questions. So I think there's a lot of ongoing questions about proteinuric and non-proteinuric CKD and whether or not different recommendations for diet should be done. That patients ask this a lot as well. So probably worth clarifying that and also differential needs in hemo versus PD versus transplant patients. So I know it's a big question, but like, from your perspectives, how would one, other than saying refer to dietitian who understands what to tell the patient, which I think is the really important thing, are there any sort of broad recommendations?
Yeah, so I think that, there's room for interpretation with protein, and we really want to individualize it. And that's why we do so many different measures of physical assessment and functional capacity. It all goes into the equation. It's not just about, 0.8 grams per kilogram or 1 gram per kilogram and go home. It's really about that ongoing monitoring. So the onus is on the dietitian or the health provider and the patient to both report back. It needs to be a dialogue to see, okay, well, we tried this intervention. How is it going? And check in, because our bodies are very, very complex. And just because we eat more protein or less protein, our bodies can adapt. So we really need to tailor it. It's a very sort of finessing moment, I would say. And I would say that by and large, we are probably not getting enough protein across the board. So oftentimes I am saying to people, you could have a little bit more. Why don't you try a bit more? Let's add a bit more here and there. And as Anja pointed out, it's really about your total amount. So as long as you hit that sweet spot of your total amount, it doesn't really matter to me how you want to do it. But, getting that total amount in is really the key piece. And yes, someone on PD might need more. Absolutely. Someone with high proteinuria might need more. My GN patients definitely need more. So, I wouldn't really go by just what we said on paper. It goes along with a full assessment. So get an assessment for sure. Ask the question. That's what we're here for. Yeah.
Great. There's also a question about socioeconomic, so like mental health, eating, and socioeconomic status and rural remote access to less processed foods. And I think it's a very big social determinants of health kind of question. But, any recommendations or thoughts as to how to help address that?
Yeah, I'll jump in. So I actually worked in Haida Gwaii, which is a really remote part of Canada. So feel very blessed to have gotten to live and work there as a dietitian. And I think that this is probably also part of my interest. So, in Haida Gwaii, we could almost always access things like potatoes, things like bananas, things like, traditional foods. We had salal berries. And, when we were restricting these foods, some of the most accessible, most transportable, right off the hop for patients, it really did mean that that box of Fruit Loops became one of the only options that was still left for them in the grocery store. And so I think that we do need to be really mindful that there is limited access to fresh fruits and vegetables. And so when we do restrict kind of across the board, we likely do a disservice to those who are living in rural, remote communities where it is that much harder to access healthy foods. And so if we can really try to keep it open and keep it mindful in Canada, where we have patients who are going to have a hard time and we need to access shelf-stable vegetables, shelf-stable fruit, fruits that are in the freezer, these sorts of things, I think are really important for us to do. And it has never been lost on me that those top three foods, like potatoes, oranges, bananas, are some of the most shelf-stable, some of the most affordable fruits and vegetables that our patients can access. And we had been restricting them without even thinking about what that downstream impact would be on what they were going to be able to eat.
Great. And then I was going to ask you one last question, which I'm going to combine two questions, which is a very common one, is what about creatine for muscle? Because there's a lot in the press and the lay press about creatine and dementia, creatine and goodness, and Ozempic and protein or muscle loss. So they go together, maybe.
I can attempt to answer this one a little bit. So for the creatine, I don't know if we've looked at it closely enough in the population. I know when I've looked it up for my transplant patients, we haven't blanket statement recommended it because we just don't study it as without the healthy population, right? With people with kidney disease. So I think.
Yeah, I think we need a study because creatine is promising. There's some promising data coming out. So I think we owe it to our patients to study these things. I think it's very important rather than conservatively always saying, no, don't take anything. We want to cause no harm. At this point, we're saying, you know, let's limit those supplements because we just don't know, they may cause harm. But we also, to your point, Adira, know that the science is changing. We're learning more about how the body is metabolizing different components. And so that's what excites me. I think this is something that we can really study in a good way. And so looking forward to that. And the second question was Ozempic and muscle loss.
Yeah.
Absolutely, it's a thing. Absolutely, it's a thing. Ozempic is not a standalone therapy. It is a multi-pronged approach that involves us. It involves, you know, the whole team, the pharmacist, the doctor, the social worker for funding. It's a big, Ozempic is a big question. And we want to make sure people we're very fortunate here, have as much access as possible so that they can optimize their therapy, but also do that sustainably. So Ozempic goes with lifestyle. You need to tap into what you can do with your lifestyle to prevent losses, to make sure you're well nourished. Different people have different side effects, some people severe, some none. So all that needs to be, you know, sort of encompassed in the care of folks who are starting on Ozempic and similar GLP-1s.
Yeah, and maybe I'd love to just add, you know, this is where that incorporation of the hand grip strength and our dyna monitors, I think, has been a really powerful tool, both as clinicians and as patients, because I think in our sort of weight bias society, you know, it's so easy for patients to say, I've lost so much weight, I feel so great. But when we're measuring their hand grip strength and if they're seeing losses in their functional status, I just feel like it's such a powerful tool and a good reminder to me too. Like, oh, okay, like your hand grip strength has gone down since you've lost this 30 pounds with Ozempic. What are we doing? And I just, it resonates with patients because they can see their number changing maybe in the direction they don't want either. So I do think that like functional assessment is great. The other thing I'll just add about supplements that's really hard in Canada, is our legislation and protection around, you know, consumers and like, is it a good quality product? And so I think that is one of the things that we do really struggle with. It's a little bit of a Wild West. It's a relatively unregulated industry. And there have been reports of, you know, supplements being marketed and not having the right things in the bottle. So it is always a tough sort of area.
Yeah. Anyways, listen, we are at time, and I'm sure we could talk about this for a lot longer. I want to thank all of you and actually all of the renal dietitians across the province, because I think you really are an amazing resource for our patients and our nurses and our doctors. We learn from you, and I really thank you for keeping us all up to date and keeping our patients healthy. So thank you very much, and happy summer, everybody. This will be our last one for the course of until September. So thank you. It was a wonderful note to end on.
Thank you.
Thanks so much.